I think that is the participation to our course. So it seems other participants are having a pleasant time outside. Since this is a course, we don't have to follow a certain schedule. If you want to talk about anything, I mean, how many specialists that we have here? You don't need. I mean, since you're an expert specialist, you don't need that course. Maybe you can lead the topic other than what I'm going to talk about. If you have any suggestions, recommendations, we can also include it. Because this course is for young people. Treatment-resistant or unresponsiveness that we talk about mostly in congresses. And also we have a method that will show you some methods. And we will have a different approach. Maybe shift of approaches. In Turkish, unresponsiveness as a term is borrowed from English. You see an article from Journal Affective Disorder. That's my article. So I wanted to mention it. Why did I write this kind of article for the journal? So psychiatric terminology comes from psychology. And when it comes to medical field, there might be some challenges regarding terminology. So when we say treatment-resistant depression, the approach is like we have an active process which we cause, but it's nothing like that. What I recommended is that we need to differentiate between treatment refractory and treatment resistant, which we use interchangeably. We need to differentiate between that so that we can do better research in terms of definition. Some favored it, but the others didn't agree. This is an interesting data. As you see, it's interesting that it's quite controversial. I mean, regarding whether depression increases or not, because the progression is important. If the diagnostic criteria are stable, then we know that we have more and more depression diagnoses. So, who has an increase in depression, especially in adolescent patients? By 63%, we have an increase in adolescents. Again, between the age 18 to 34, we have an increase by 47%. All in all, depression is more common nowadays. Which brings together that when you look at the factors, you will say environmental and genetic factors. And when it comes to environmental factors, they somehow are more affecting the situation. So this changes our perspective on depression, which led to a challenging situation in the data. From Social Security institution, they told us prescribed use of antidepressants increase. You see insurance corporations called Blue Cross and Blue Shield data. For patients using antidepressants, you see we do retreatment when there is unresponsiveness to the antidepressants. We have two questions. One, why antidepressants don't work for 60% of the patients? And according to this data, does depression increase? This may not be ending point. We have another parameter regarding increase of depression, which is suicide rates. In the chart you see Turkey's and America's suicide rates. Looking back at 90s, when antidepressants used commonly, we see a decrease. It seemed antidepressants were useful, but after 2000s, we have an increase in suicide rate up to 20%, and also fatal results that we have here. In Turkey, compared to America, we have an increase. This is a quite nice study. I don't know who conducted it, but it has nice outcomes. You see the increase in female patients, and then we have stabilization, but it increases in male patients. But what concerns us is that we know that when compared to America, it is 1/3. But the most important thing here is suicide rate is gradually increasing. So in 2000s were the prime time of the treatment of depression. So we need to question why the suicide rate is increasing. In order to treat a disease or depression, you need a very nice diagnosis, because without diagnosis there is no point in treatment. If you don't do a proper diagnosis, then it doesn't matter what you treat. At the first stage, there might be misdiagnosis of depression. 40% of the disease came from misdiagnosis, where patients were diagnosed with depression which was false. It's not that antidepressants are not useful. It's because that we don't properly diagnose depression. I am trying to do jokes here, and if you smile every now and then, I will be very glad. If there is depression in family history, then doctor can easily diagnose the patient with depression. And the patient refers to us saying he or she has problems, but we don't question the period. In polyclinic, when the patient comes to you, the severity, maybe there was some problems before, but if it is over threshold, we don't question the period. I mean, how long the patient is depressed. Therefore, if it is under the threshold, then it will lead to misdiagnosis. So you need a careful examination. When it is female patients, we tend to diagnose with anxiety and depression easily. The key point here is 2 weeks of period. There might be external factors like breaking up with your boyfriend or girlfriend, and patient refers to it with problems like that, justifying their problems of Therefore, we have low response to antidepressants. Common anxiety disorder is another thing that was confused. Common anxiety disorder was described by 1%, but now it is more and more common. Also, we always complain of misdiagnosis. Anhedonia can be seen in patient, but there might be depression or regarding to its function. So there are some situations where we cannot properly diagnose the patient with diagnosis, which will lead to misdiagnosis. In our own team, each staff working on depression, we try to be sure of our diagnosis of the patient. So they also collect under threshold cases, working on larger groups, but we don't have desired outcomes still. Unhappiness and depression or disappointment are not same things. I mean, you can be disappointed in different circumstances, or you may be disappointed because of your expectations, but it's not the same thing as depression. I mean, a person gets married and then he or she has disappointment about the marriage. So does it mean that the patient is depressed? No. Maybe because he or she cannot divorce, it leads to unhappiness, but it doesn't mean it is depression. And they tend to treat it with drugs, and then it doesn't work because it's not depression. There might be grief, primary anxiety disorder, and bipolar 2 is also confusing since it has complex features. Also, if it is personality disorder or not. Alzheimer's disease is another severe factor. Starting from the age 50, patients may develop Alzheimer. First symptoms look like depression, but it is more like dementia. It goes to Alzheimer's disease. Also, substance withdrawal is another thing. She's not speaking to the mic, so I cannot hear, sorry. You are very right. Yesterday, in a presentation, it was quite interesting that in early adolescence, starting from the age 12, the activity is a little bit over the limit.
Ama 13-14'ü geçtik.
After the age 14, straight activity lowers down. So this can be confusing. I don't know if you agree, but we have systems that stimulate our children dopaminergically, like video games and TV shows. So dopaminergic system can be stimulated by them, but when they get away from the stimulants, then along with physiological reduction, then we see unhappiness in children. I agree with you about this. I will add it to my slide. I didn't add it in my book, but I'm also going to add it in my book. We have written it down, but it's not read. This course should be interactive, so I just don't want to be the only one that talks. Your experiences are quite important because we focus more on research. Also, the feedbacks are quite important clinically. Another challenging and controversial part is clinical depression. Since it is dysthymia-like, it looks like unresponsive. It looks unresponsive to the treatment, but chronic depression means that it needs to last over 2 years. Some of the depressive patients come to us like that. It should be over 2 years. And you shouldn't call them persistent depression if it is over 2 years. 25% of the depressed patients stay at a chronic level, but it still means it is not but it still doesn't mean it is resistant. This is refractory. So the patient recovers to some extent, but no further. And do we have anyone from drug firms? No. Nice. Today, the antidepressants we use may not be called as antidepressants, to be honest. And 30% of the patients are recovered, but In some patients, it is residual. We want the recovery. What about insufficient response? When there is unresponsiveness to the antidepressants, if it is refractory, we have two types of treatments. And if the patient do not respond to treatments or more, then it is getting more and more refractory or persistent. Hamilton is not a nice scale to assess depression because of its somatic features. Anhedonia and losing interest in the things that patient used to do because of affective networks dysfunction. The two of them are important, and the other 7 symptoms. Also, since Hamilton just questions them with just one question, it's not enough. There was a study including depressive mood and anhedonia. Those are the questions that we ask to diagnose depression. In melancholic patients, Hamilton is 22, but in depression patients it is 26 in terms of Hamilton score. So if there is no response to treatment, then we may think that it is severe depression. So there are some confusing results. So we shouldn't confuse the severity of depression with chronicity and severity. Those two are important concepts. In as much as they seem parallel, they are not related to unresponsiveness. Depressive nature, despair, suicidal thoughts, psychiatric anxiety, sleep disorders, and also the sense of guiltness, psychomotor slowing. So those are related to the unresponsiveness to the disease, the treatment. So the first 3 symptoms are more related to anxiety. So here we have some additions from another group in order to differentiate between standard depression. And in the general pharmacological terminology, if you check Hamilton's score, if it is under 25%, then it means the patient will be treatment unresponsive. There will be unresponsiveness to treatment. If also remission is another term that is used. Why 50%? Up to now, do you have any question or contribution? We have STAR-D chronic. It is quite important because it is the first time that much of data were compared. As you will know, STAR-D study were conducted with standard patients. Why? Because comorbidity and also in terms of anxiety and any medical conditions or suicidal patients, those patients are excluded from drug studies. In STAR-D study, we see that chronic comorbidity and patients with suicidal thoughts were included. So we have a wider audience. First step in STAR-D is we give stirpram to patients, which we also use commonly as antidepressant. Between 20 to 40 milligrams that we use. Here, when we look at STAR-D study, between 2-week interval, we check the scores of the patients. Hamilton is also used, but we have another scale here. I don't remember its name, but I guess it's IDS. In the second week, you see 11% of the patients have remission. In fourth week, it reaches up to 19%. And then 20% of the patients stay at remission because we have relapse in this remission group. However, 52% of the patients at the end of the 6th week have remission. So sixth week comes from there. Half or more than half of the patients have remission. So the finding is 6.7 week. So what are we going to do starting from week 6? So you give the patient tolopram and the patient had remission. What are you going to do after that? Some say that they will go for the increase in dosage. We have written it all down, but nobody reads it. I mean, I am speaking generally because it is commonly discussed. Because dose increase is commonly preferred. They ask psychiatrists, and most of them say that they are going to go for dose increase in dosage. And I also asked my other colleagues. So most of them favored increase in dose. The critical point here is, and should we increase dosage or should we continue starting from week 6? Because most of the patients recover after the 6th week. And there are such studies considering what happens if we don't increase dosage. In USA it is 40%. And we have a study in USA, the dose is 100 milligrams. So what happens when we stay at 100 milligrams, and what happens if we go for 200 milligrams? But the study showed us that 100 milligrams is the better one. Increasing the dose is not that much practical biologically. So up to the rate of responsiveness is up to 12th week. So sometimes patients may complain because they do not recover. Increasing the dose is an option, but it seems that even if you don't increase the dose, in fluoxetine maybe you can give 20 to 40 milligram, in Favorin up to 150 milligrams. When you continue the dose, remaining group by 30%, it is useful. So the patients should be patient. And I am also well aware of that.
Ne yap?
Psychiatrists were also asked. I present them with SSRI, then I increase the dose, then I change the SSRI and switch to SNRI. I think that's what we do mainly.
Bir şeyler de düşünüyor. STAR-D çalışmasını yapanlar da düşünüyor.
So in study trial, it is considered that let me go this way. I'll administer them with bupropion with a different effect mechanism. So it's dopaminergic. Then I switch to another SSRI like sertraline, and I move to venlafaxine, or move on to SNRI just like psychiatrists do. The alternative is to move into a combination therapy like buspirone or bupropion. This seems very reasonable as a method. And that's actually what we do. We either switch to another medication or we switch to another method for augmentation. Now what happens then? If, due to adverse effects, patient had to end up switching or quitting the medication, then their response to the next medication is almost similar to when we start the medication in the first place. If the patient does not respond to the treatment as expected, then the response we get is about 20% less. So we administer citalopram, use it for 6 to 8 weeks, then we switch to sertraline, and our expected response rate decreases by 20%. But when we move to sertraline due to adverse effects, then the expected response is almost similar to the initial beginning of the medication.
Bupropion, gerek sertraline, gerekse venlafaxine.
Also in venlafaxine and sertraline seem to have no differences, but there seems to be a criticism here. Venlafaxine average dose is around 194 milligrams per day, and in our clinic daily dose this is lower. As you know quite well, when you increase the dose of VLF, it results in the system, effects in the system changes, and higher dose sometimes is more effective. And what is your highest dose with venlafaxine, please? 375. In a high and rapid dose, we can go up to 375 and get very good results. Not 150, I suppose. Might be different in children, yes. Now, for venlafaxine, the biggest disadvantage is it has low protein content when it binds, so the free cap fraction is high in venlafaxine, meaning noradrenergic feedback pumps are inhibited, which increases the BP. So we actually feel a little bit concerned when we use it, but if we're switching from SSRI to venlafaxine, in which the rate is not very high in terms of effect, we don't switch at any dose below 225. Our highest dose was 600.
Çıkmanızı bazıları son.
And sometimes some physicians are rather against increasing the dose that high because it metabolizes very rapidly, not because of the dose itself. So now the question that comes to mind with STAR-D trial is, okay, we may lose the efficacy of the medication when we switch up to 20%, so can we start with dual therapy? You could start dual antihypertensives. As far as antidiabetics, I don't think they are initiated in dual therapy form. So we always ask, why can't we start like that? And a new trial was conducted, and in the primary research there was a serious effect, and there was a larger, more extensive trial. The first one comes from Europe, the second one comes from the US. 665 patients with moderate to severe depression, 12 weeks plus a 7-month follow-up is present. The key thing here is that the use of depressives and antidepressives may end up without any response. So what is used here? Escitalopram up to 20 milligram per day plus placebo. Also escitalopram plus bupropion was also administered in the second arm. Bupropion has low sexual side effects. We can go up to 400 milligrams per day, but we don't want to exceed that, as it could induce epilepsy. And venlafaxine plus mirtazapine was the third arm. All three were researched. And venlafaxine plus mirtazapine is rather strong, and the third one should work. But at the end of second week, there's no difference. So, starting dual therapy in terms of remission is not really different from starting with escitalopram. If you look at 7-week continuation phase, we see that there's a minor improvement in the patients remaining in the same group of medications. Looking at the rates, we see that there's a 15 to 20% increase. Improvement, rather. So, at the end of 3 months, when patients take antidepressants, they may go into remission. However, at the end of 7th week, there's no statistically significant difference by then. So when you combine the medications and increasing the monoamine, it doesn't really make any sense practically. There's the study trial, and the response decreases after every stage. Now, this is not very important. Now, we could take a look at the decrement in the response. So we administered these 3 medications, venlafaxine, bupropion, and sertraline. Not very significantly different. There's a 20% decrease in the rates of remission. When we add buspirone or bupropion, what happens? There seems to be a small augmentation. Now, in augmentation, our targets is about 10 to 15%. Not much happened in buspirone, but in bupropion there seems to be a significantly better result. The basic issue here is, after 12 weeks, when you add bupropion, are we getting better results because we added bupropion, or would the results be much better after 12th week? As it was not very positive with bupropion, then probably bupropion induction seems to be of some favorable response in some group of patients. Now, when we bring together the data of the 2 trials, starting dual therapy does not seem to make sense, but adding bupropion later seems to be giving us the edge. If we add lithium or T3 to the existing medication, what happens then? There's a very tricky issue here. When we add lithium, most of the patients that benefit from that have either a borderline personality disorder like borderline or narcissism, at least related to bipolar disorder, or is bipolar. So there must be either family history of bipolar disease or personality disorders, or the patient must be bipolar, seems to be at least. So it seems rather different, but when the patients receive T3 and lithium, we don't really see a difference here. T3 patients seem to tolerate it better, and lithium receiving patients cannot really tolerate lithium well. That's why there's this prominent dropout, and lithium also not give us results that we have expected. So at the end of the trial, now maybe seeing that this does not work, we could move on to antidepressants with dual effects. So mirtazapine could be applied, or NTP. However, when they are administered, the difference again is minimal. Venlafaxine plus mirtazapine and MO inhibitor are tried together, and then we don't really see the pronounced effect we were looking for. So what we see is after each antidepressant effort there seems to be a loss, and at the later stages the response to therapy decreases drastically. However, that's not the end of the story. We also come up against something else, and you're not really told that this, by the way. Some of the patients in remission within the first year relapse, because people think, right, I have administered the patient with this, is now in remission, it's okay, maybe not respond to acetoprolol, I switch to sertraline, and some of the patients have moved into remission. At the end of year 1, what happens? What happens is up to 40 to 70% of the patients demonstrate relapse.
Yani o kadar uğraşıyorum ama yine relapse.
So I'm actually dealing with this patient. I'm doing all I can, and there's still relapse. And this is something that we tend to overlook in these trials. Yes, please. Despite the use of medication, yes. So from escitalopram, the patient has moved to switch to bupropion, or either combined therapy is used. You just start to follow the patient up at the end for 1 year, and at the end of the first year, what you see, the patient is in relapse. Any further questions or contributions? I'm actually looking for some feedback from you. That's why actually I have arranged this session, but you're receiving information from my presentation anyway. Now, if the patient has not benefited from SSRI, then we could switch to the medication with dual effect. No benefiting from SSRI, the patient might move on to SNRI, venlafaxine, for example. Loxetine is not really bright, and venlafaxine's contribution is not really prominent as well. And we also have NNT. And with NNT, what is the rate of difference we're going to see in a patient group? 1 or 2? Similar to antibiotics. So with antidepressants, the response rate is 1 in 6. So in every patient we administer antidepressants, 6 patients, we only receive response in 1 of them. What about from SSRI to SNRI? 1 in 22 patients. That's the level of effect. So 21 of 22 patients do not improve.
Venlafaxin ya da benzeri bir ilaç.
So we actually administer venlafaxine or a similar medication. It is a very low success rate. So why do we move on from SSRI? Because in the previous patient, use it for 6 weeks and you administer another medication, and the system seems to be improving, and when you administer another medication, what you end up with is completing the cycle of administration. A study from Helen Mayberg, not Warden, sorry for that. A very important thing is present here. Now, Helen Mayberg, in the beginning, performs PET CT scan on patients in the first week and 6 weeks and looks at the changes. In the first week, the most important change, it happens in Pons region. So there's a change here, and this change does not demonstrate any difference between responding and non-responding patients. So at the end of the first week, in rapid nucleus, there seems to be an activation. So antidepressant is actually doing its job. On week 6, for example, in anterior cingulate cortex, activation decreases, and in some other areas, activity increases. Now, this increased activity is seen in frontal cortex. And in subgenial area, there's a decreased activity. What strikes me here is there seems to be an activation in the pons in almost all patients. However, in the patients responsive to treatment, this activation continues and also triggers activations in other regions of the brain. But in non-responsive patients, we don't see that. Which shows us that to whomever we administer the medication works. But at the end of week 6, this system works in some of them, while it doesn't in others. And this is a system that actually disseminates in all of the brain, so maybe it fixes something in the brain in a certain region, but in other regions maybe it doesn't. Another interesting trial was conducted with paroxetine. So paroxetine was administered, and then in patients with no response, then paroxetine doses increased. So blood plasma levels were researched, and also how the involvement in the brain is also observed. Now, where we arrive is by increasing the dose, the involvement in the pump doesn't seem to increase prominently, no matter how hard you try to increase the plasma level. So serotonin pump needs to be blocked by 80%. When it's blocked up to 90%, it does not work. So if 80% works, it's fine. If it's 90%, no response. So extra dose, additional dose doesn't help. That was one of the most important findings of this trial. Now, our main target is making sure 80% blockage occurs. We could do this with 50 or 100 milligrams of sertraline or others. But the thing is, if we change the dose over this amount, it doesn't help us one bit. So if the patient is going to benefit, it only happens with 80%. So these sort of patients are not resistant patients, they are refractory patients. So we haven't administered the true system. We have only one system, the serotonin system. And what we try to do is we try to fix that. However, that is not the right system for this patient. Dopaminergic, serotonergic and noradrenergic systems sometimes overlap in terms of where they end up. When you intervene with one of them, the other two also changes, because they are systems that are in a certain balance and overlap. So, okay, let me remove one of them and add the other one. These are the sort of involvements or interventions that does not contribute to the response, expected response of the treatment. Obviously, we're talking about normal physiological range. So, we're not talking about administering cocaine and expecting serotonin to fix it. So 1 in 22, that's why 1 in 22 is the rate for the response rate. In meta-analysis, we see that antidepressants, give or take, have a similar impact. The reason for that is these two systems are not really different from each other. Just take a bottle of water.
Şimdi peki o zaman bana şunu diyebilirsiniz.
Well, you could say to a group of patients that the antidepressant I have administered doesn't work, and you are not resistant, you are refractory patients. And the reason for that is that these patients maybe are not coming up against the correct medicine. There are some other mechanisms, such as hormonal activities, immunologic system, neurotropic factors, or other DB systems. While we are fixing one system, we're expecting other systems to get fixed. However, we do not have that medication that can fix all the systems. Depression is an output. Therefore, many things can cause depression. For that reason, if we try to intervene only with the serotonergic system, we can't really fix everything. Lithium, for example, fixes a lot of things. So that's why one of the reasons that lithium works in a group of patients. Now, looking at STAR-D trial, lithium didn't seem to be very advantageous. However, you could read it in our book that lithium works in a lot of patients, and it has to be tried as a method. T3 is not available in Turkey. I wish it were, because T4 doesn't function in the same way. While we're writing this book, esketamine was not approved for the markets. It was approved in December, and we finished our book back in November. Well, life moves on fast. Now, a different process has begun. I block the lady receptors, and then once GABAergic NMDAs are blocked, other glutaminergic neurons may end up functioning more, causing more glutamates. And that's a theory for esketamine. So what happened here is another system other than serotonin was sort of infiltrated. Now, for esketamine to work for today daily practice, when we administer opioid antagonist, the effect of esketamine disappears. So it seems to be working on opioid as well. Depressive patients are not addicts to opioids. That's something we know for a long time. And there are many cases where opioid has been administered for treatment, and one of them is the medication we call ALKS5461. This blocks the MO receptors for addiction, and then it warns the other systems. So we see that patients may respond in different ways to certain treatments. So if one patient does not respond to antidepressants available today, we should not call this patient resistant, but call the patient non-responsive or refractory, because the patient doesn't seem to resist. The problem is we can't administer the right medicine. Now, let's go back to relapse. Yes, please. Combining two SSRIs together? Okay. Now, using two SSRIs together doesn't mean there's going to be a practical benefit. On the other hand, when we look at the patients, SSRI is a genetically coded and individually different molecule. Some medications cannot be bound to some pumps. So, if you administer two medications together, you decrease that risk. But trying first and administering the other afterwards is possible. Another alternative is using venlafaxine plus SSRI. Now, in that, patient may not benefit from the dose of venlafaxine, but you can't increase the dose for further benefit. So sometimes for augmentation, when we add SSRI, that's a method we sometimes apply, but both focus on serotonergic system, meaning if there's a response there's a response. If not, then the patient is refractory. But if you have further experience, I'll be very pleased to hear.
İkisini birlikte kullansam.
So if I use both together, I've actually tried that. And, well, they are patients, after all, and they may be aware of which medications they benefit from. So there were some instances when I got better results. If I give an answer as an American, I'll say it has no correlation. And if the patient says he benefits from this, we should not stop that. That's what I think as a clinician. And why? Okay, I benefited from both. So if one thing is good and another thing is also good, and if I use both of them together, am I going to get better results? That's the question I should ask. And the data we have currently does not validate your observation. And the existing data is not telling us this story. If the patient is not going to sue you afterwards, because no expert will approve this, we need to look into it. Well, it's quite obvious that we don't know more things than we know. So, as for effect mechanism, they inhibit both same pumps, and maybe increasing the dose might be attempted rather than using two different medications. Now, one handicap that needs to be taken into account here is 3 or 4 might be blocked. Therefore, you end up increasing the dose and effect. I'm not sure if you can increase the serotonin, but it is certain blockage appears in the brain, but the main serotonin is not in the brain, it's in the GIS system. So do you end up increasing the cycle of serotonin in the GIS system? I'm not sure. Maybe 5-HT2B blocking medication can be added to that so that you could actually play it safe. I don't know if there are other people with further experience, but you definitely need to consult an expert in that regard. Now, talking about relapse rates. This is the same chart. In some patients we saw some relapse, and when taking antidepressants, if there's a relapse that occurs, you end up asking a question: do the patients develop tolerance? Sometimes people who are rather illiterate but think of themselves as rather knowledgeable end up on TV and say, antidepressants don't work, my brother was taking antidepressants and he died. Now, that's not the case obviously, but sometimes relapse occurs and we need to accept that. Sometimes from switching of dose or changing of dose or switching the medication helps the patient benefit from the treatment. So at the end of 6th month, the response may be worsens, and then you switch and you get better results. Now, and main reasons for that are pharmacokinetic. Now, in the first year, 23%, and by the 3rd year, 45% relapse rates are present. And despite the changing of antidepressants, depression persists. So, this system, the monoaminergic system, stops responding. That's what we call resistant depression. Looking at medicine, resistance to treatment usually occurs in cancer and sometimes in infection patients. Now, Initially, when the patient was responding to the treatment, initially, a system changes, either the genetic of the bacteria changes or a neuroplasm, there's a neoplastic impact on cells change due to a mutation or another system. So there's an active process. It is rather possible that at the end of the first year in our patients, rate of 20% of relapse is because of a certain change. But as we have not differentiated so far between the patients who are refractory and resistant to treatment, that's not something we have focused on yet. So if the patient is receiving antidepressants, and after a certain amount of time, by excluding the placebo effect, at least within 2 months, if there's no response to antidepressants, then we should consider this patient as resistant. But if we cannot administer the patient with the right medication and no normalization occurs, then we should exclude those patients from resistance group. Where we end up here is we have two types, type 1 depression and type 2 depression. Type 1 depression is the depression where we receive a response to treatment from first or second antidepressant use. That's type 1 depression. Type 2 depression are pseudo-depressions. They don't respond to antidepressant therapy, the reason being not antidepressant properly functioning. The reason is patient has problems adapting to the medication, or there may be some other accompanying diagnoses, Alzheimer's, etc. So because of the diagnosis, or maybe because of the lack of adaptation to treatment by the patient, problems occur. 18% of the patients are refractory patients, meaning they don't respond to monoamines. They have never responded. I mean remission. Meaning they have never reached normal remission. So antidepressants and the response to antidepressants at a refractory phase. 7% have responded previously, but after a period of 2 months, and sometimes longer, like 6 months or 3 years, their response to antidepressants has gained resistance despite our best efforts. And that's the most problematic group of patients. That's the end of my presentation.